Welcome back to the deep dive. Today we are tackling a system in the human body that is, and I'm not exaggerating here, nothing short of a biological miracle.
It really is. It's a system that has to do two completely contradictory things.
All the time.
Every single second, yeah. It's the ultimate high-wire act of human physiology.
Exactly. I'm talking about your blood. Specifically, this paradox that your blood needs to be a liquid. It's got to flow freely through miles and miles of blood vessels, right?
Yeah.
Delivering oxygen, nutrients, keeping you running.
Right.
But the absolute second you get a paper cut, or nick yourself shaving, or have a major injury, that liquid has to instantly, and I mean instantly, turn into a solid. It has to seal the breach.
And has to do it only at the site of the injury. That spatial control is, well, it's everything. If it solidifies everywhere, you die. That's thrombosis.
Right.
And if it stays liquid when it shouldn't, or if the seal isn't tight enough, you bleed to death. That's hemorrhage.
So it's this perfect Goldilocks system. Not too liquid, not too solid. It has to be just right. And today, we are diving deep into the pharmacology of coagulation. We're looking at how we use drugs to sort of hack this system when it goes wrong. We've got a massive stack of research today, and we're primarily drawing from the absolute Bibles of pharmacology Goodman and Gilman's, the pharmacological basis of therapeutics, and Katzung's basic and clinical pharmacology.
These really are the heavy hitters, and the way we're going to approach this is by synthesizing the two. Katzung gives us that incredible clinical clarity. You know, how do we treat the patient sitting in front of us? It organizes the chaos.
In Goodman and Gilman.
That's the mechanistic depth, what is actually happening at the atomic level when we give these drugs. That molecular understanding is what separates a technician from, a true expert.
Right, and just to set expectations for everyone listening, this deep dive is an interpretive synthesis. We are not a replacement for the textbooks.
Not at all.
We are trying to create a conceptual map so that when you go back and read the chapters, specifically blood coagulation, and anticoagulant fibrinolytic and antiplatelet drugs in Goodman and Gilman, and drugs used in disorders of coagulation in Katzung, you'll have a framework to actually understand what you're reading.
Exactly. We want to give you the why so the what actually sticks.
Yeah. So here's what we want you to have in your head by the end of this. First, we need to see hemostasis not as a list of Roman numerals to memorize for a test, but as a system of interacting parts platelets, factors, fibrinolysis.
It's a network.
Second, we need to understand the targets that really matter, thrombin and factors A. These are the big ones.
Third, we need to get the fundamental difference between anticoagulants and antiplatelets. They treat totally different problems, they use different tools, and they carry very different risks.
And finally, we're going to make the trade-offs explicit. Every single time we intervene in the system, we are trading efficacy for bleeding risk. There is absolutely no free lunch in anticoagulation.
No.
And we're going to synthesize all of that. But before we get into the molecules, I want to start with a story. This is a case study straight out of Katzung, and I think it perfectly sets the stage for why this matters. Because when this system fails, it fails fast.
Oh, it's a classic presentation. Every emergency physician recognizes this one immediately.
Okay, so picture a 25-year-old woman. She's young, healthy, living her life. She walks into the emergency department because she's short of breath. She's got this sharp, pleuritic chest pain, meaning it hurts every time she breathes in.
Like a knife.
Exactly. Feels like a knife in the chest. A couple of days ago, she noticed her left leg was swollen and red, maybe a little tender, but she didn't think much of it. She thought maybe she pulled a muscle at the gym or something.
That leg pain is the critical detail. That is the herald of the storm.
Her only medication is oral contraceptives. And she mentions that some women in her mom's family have had blood clots before.
A huge red flag.
They check her oxygen, and it's surprisingly low, 87% on room air. That is terrifyingly low for a healthy 25-year-old. So they do an ultrasound of her leg and boom deep vein thrombosis, a DVT. Then they scan her chest, pulmonary embolism, or PE.
This is the nightmare scenario. This is a total failure of that Goldilocks system we just described. This is a provoked event. The estrogen in the contraceptives acts as a procoagulant.
It tips the scales.
It tips the scales. You combine that with a likely genetic predisposition from her family history, and the balance tipped toward clotting. The flow stopped in her leg. A clot formed in those deep veins. A piece of it broke off, traveled up through her heart, and got lodged in the arteries of her lungs. She is, for all intents and purposes, suffocating because blood can't get to the lungs to pick up oxygen.
And the mission of this deep dive is to understand exactly how we save her, We need to move beyond just memorizing lists of drugs. We need to understand the logic of the system. I remember in med school, the coagulation cascade was this terrifying chart of Roman numeral.
Oh, I remember.
It seemed to have no rhyme or reason. It looked like a subway map designed by a chaotic, evil architect.
It haunts the dreams of every medical student. But the goal today is to strip away that confusion. We are not just going to recite Roman numerals. We are going to look at hemostasis, which is the fancy word for stopping bleeding, as a dynamic, regulated process.
Right.
We'll look at the system itself, how the body plugs a hole. Then we'll look at the anticoagulants, the drugs like heparin and warfarin that stop the clotting. We'll look at antiplatelets, which are a whole different ballgame. And finally, the fibrinolytics, the clot busters.
So let's start at ground zero, the system. You get a cut. What actually happens?
There are really two parallel systems that spring into action, and it is so crucial to distinguish them because we have different drugs for each. We call them primary hemostasis and secondary hemostasis.
I've heard this described as bricks and cement. Is that fair?
That is the best analogy,
Fair.
Absolutely. Primary hemostasis is the formation of the platelet plug. The platelets are the bricks. Secondary hemostasis is the coagulation cascade, which creates a protein called fibrin. Fibrin is the cement that seals all the bricks together. You need both to build a wall that can hold against the pressure of blood flow.
Okay, let's talk about the bricks first. The platelets. These are just, floating around in the blood, minding their own business.
Correct. And this is a point Goodman and Gilman really stresses. In a healthy blood vessel, the lining, the endothelium, is actively telling the platelets to stay calm.
So it's not passive.
Not at all. The endothelium isn't just a passive pipe, it's a metabolic organ. It produces nitric oxide and prostacyclin.
Nitric oxide and prostacyclin.
These are basically chemical chill pills for platelets. They keep the intracellular calcium low inside the platelet, keeping them inactive, smooth, and just flowing down the center of the vessel.
And it's negatively charged too, right?
Yes, the endothelium has a negatively charged surface, and so do the platelets, so they repel each other. It's like Teflon.
So the default state is don't clot. That's really important to remember. We aren't just waiting for a clot signal. We are actively being suppressed from clotting.
Exactly. But when you slice a blood vessel, say a paper cut, you break that endothelial lining. You breach the Teflon. You expose what's underneath the subendothelial matrix. Specifically, you expose collagen and a large protein called von Willebrand factor, or VWF.
Von Willebrand factor.
Yeah.
That sounds very aristocratic, like it should be wearing a monocle.
It kind of acts like a grappling hook or molecular Velcro. The platelet has a receptor on its surface called glycoprotein I, or GPI. It sees that exposed von Willebrand factor and it just grabs onto it. That is the first step. Adhesion. The platelet sticks to the injury site.
Okay, so the brick has been laid, but just sticking there isn't enough, is it?
No, not at all. A single brick isn't going to do much. The platelet, once it sticks, it gets angry. It activates. This is a dramatic physical transformation. It goes from a smooth little disc to this spiky sphere, shooting out pseudopods to increase its surface area. It flattens out to cover the hole, and then it starts screaming for help.
Screaming chemically.
Yes. It degranulates, releases these granules containing chemical recruiters, things like ADP, thromboxane A2, and serotonin.
Okay, let's unpack those. ADP and thromboxane A2.
ADP is a really potent signal that hits receptors on nearby platelets. Thromboxane A2 is synthesized on the spot from arachidonic acid, and we will absolutely come back to that when we talk about aspirin. These chemicals float downstream, hit other platelets that are just passing by, and turn them on too.
So it's a chain reaction.
A huge one. It causes those new platelets to become sticky as well. This is the activation phase.
It's a riot. One guy throws a brick, and suddenly everyone is throwing bricks.
Precisely. And this leads to the third step, aggregation. The pile of bricks grows. And here's a mechanism we need to flag because it becomes a major drug target later. When a platelet activates, a receptor on its surface called glycoprotein I changes its shape.
GPIBA. Okay, got it. Why is this receptor so special?
This is the most abundant receptor on the platelet surface. Think of it like a pair of hands that are normally clasped behind the platelet's back. When activated by ADP or thromboxane, those hands reach out. And what do they grab? They grab a molecule called fibrinogen that is just floating around in the plasma.
Fibrinogen, that's a protein.
Yeah, a large dimeric protein. It acts like a bridge. So one platelet grabs one end of the fibrinogen molecule with its GPIBIAs, and another platelet grabs the other end. They're now linked.
Like holding hands.
Or maybe more like being handcuffed together. This happens millions of times, forming this cross-linked clump. That is the platelet plug. Now, for a tiny cut, like a pinprick, this might actually be enough, but for a real injury, this plug is really unstable. It's just a loose pile of bricks held together by handcuffs.
The blood pressure would just wash it
Yeah,
away.
exactly. It would just wash away. So now we need the cement.
Secondary hemostasis.
The coagulation cascade. This is where those Roman numerals come in. But let's focus on the logic, not just the list. The goal of this entire cascade, all the steps, all the factors, is to generate one specific enzyme, thrombin.
Thrombin is the boss.
Thrombin is the CEO of coagulation. Everything leads to thrombin. But you don't want thrombin floating around active all the time, or you just clot instantly.
Of course.
So it exists as a zymogen, which is just a fancy word for an inactive precursor. It's called prothrombin, or factor 2.
So zymogen is like a safety catch on a gun.
That's a great way to put it. Or a grenade with the pin still in. It has the potential to explode, but it needs to be triggered.
Okay, so how do we wake up the CEO?
Yeah.
How do we pull the pin?
We need a trigger. And the main trigger in the body is called tissue factor. Remember how we said collagen is exposed when a vessel is cut? Tissue factor is also exposed. But it lives outside the blood vessel. It's on the surface of cells in the muscle and tissue surrounding the vessel. It's like a landmine just waiting for blood to step on it.
So blood is flowing, it breaches the vessel wall, hits this tissue factor, and boom.
Boom. Tissue factor grabs factor 7 that's floating in the blood. This is the extrinsic pathway because the trigger, tissue factor, comes from outside the blood. Tissue factor plus factor 7 starts a chain reaction, and they activate factor X.
Factor X. X marks the spot.
It really does. Factor X is the convergence point. This is crucial. Whether you start with the extrinsic pathway or the so-called intrinsic pathway, which we can touch on, they both end up activating factor X.
Wait, let's briefly mention the intrinsic pathway just so we don't leave people hanging. That's the one that starts with factor 12, right?
Right. It's called intrinsic because all the components are already inside the blood. It's triggered by contact with negatively charged surfaces. In the lab, that's a glass test tube. In the body, its role is a little less clear. And Goodman and Gilman makes a fascinating point here. People who are born completely missing factor 12. They don't bleed.
They don't bleed. That seems completely counterintuitive.
Yeah.
If you are missing a clotting factor, shouldn't you be a hemophiliac?
You would think so. But no, factor 12 deficiency doesn't cause a bleeding disorder. This suggests that for physiological hemostasis, stopping a bleed from an injury, the extrinsic pathway with tissue factor is the real workhorse.
So what's factor 12 for?
It seems to be more involved in things like inflammation and fighting infection. However, and this is a big however for medical devices, factor 12 does cause clotting on artificial surfaces like stents, catheters, or mechanical heart valves.
Ah, okay. So for our 25-year-old patient with the DVT, the extrinsic pathway is likely the main driver initially, but then the intrinsic pathway acts as sort of an amplification loop to make the clot bigger.
That's it, exactly. The intrinsic pathway is like a turbocharger. The initial spark is tissue factor, but the intrinsic pathway revs up the production, and both pathways activate factor X.
Okay, so we're at factor X. What does factor X do?
Factor X is the enzyme that turns prothrombin, which is factor 2, into thrombin, which is factor 3. Now, the CEO is awake.
And he's got a to-do list.
He does. First, thrombin acts on fibrinogen. Remember that protein linking the platelets? And it chops off little pieces of it. This turns fibrinogen into fibrin.
And fibrin is the cement.
Fibrin monomers link up spontaneously to form a mesh. It's like a net that traps the platelets and the red blood cells. Then, thrombin activates another factor, factor 13, which is a crosslinker. It effectively staples the fibrin net together, creating these really strong covalent bonds. Now you have a stable, solid clot.
Amazing. So we've gone from a liquid to a solid plug in just minutes.
Yeah.
But there's one more piece of physiology from the Goodman and Gilman source that I found fascinating. This doesn't just happen in the liquid blood, right? It all happens on surfaces.
This is so crucial for understanding the drugs. It's the part that gets glossed over in simple summaries. Coagulation factors aren't just swimming freely in 3D space when they react. They assemble on the 2D surface of the activated platelets. The platelet membrane provides a kind of a dance floor for these proteins to meet.
So they don't just drift apart.
Right. If they met in open space, they'd drift apart before they could react efficiently. The surface concentrates them.
Then what holds them on the dance floor?
Calcium. And this is where it gets really molecular. Factors 2, 7, I and X have a special chemical modification called GLA residues. Basically, the liver adds extra carboxyl groups to glutamic acid residues on these proteins. This gives them a really strong negative charge.
And calcium is positively charged.
Right. Calcium plus first.
Mm.
So calcium acts as a bridge. It binds to the negative platelet membrane on one side and the negative clotting factor on the other. It anchors them.
The calcium sandwich.
The calcium sandwich, exactly. And how do they get those GLA residues? How do they get that negative charge? Vitamin K. The liver uses vitamin K as a cofactor to add those extra electrons to the factors. It's a process called gamma carboxylation. Without vitamin K, the liver still produces the factors, but they're toothless. They lack the negative charge. They can't bind calcium. They can't stick to the platelet surface. They can't dance. They just float on by.
That is huge, huge foreshadowing for warfarin.
Hmm.
Okay, so we have the system. Platelet bricks, fibrin cement, calcium anchors, vitamin K manufacturing. Now let's go back to our patient. She has a clot where she shouldn't. We need to stop this process. We need anticoagulant.
Right. And usually the first line of defense in a hospital setting is going to be the parenteral anticoagulants. That just means injectables. And the grandfather of them all is heparin.
Heparin. It's one of the oldest drugs we have, isn't it?
Discovered in 1916 by a medical student, actually, J. McLean. He was looking for a procoagulant in dog liver and accidentally found an anticoagulant. Total serendipity.
And heparin is fascinating because it's not an inhibitor itself. If you put heparin and thrombin in a test tube alone, nothing happens.
It does absolutely nothing on its own. It needs a partner. Your body has a natural policeman called antithrombin. Antithrombin is a protein that prowls the blood looking for active clotting factors like thrombin or factor Zea to, arrest them. But normally antithrombin is slow. It's kind of a lazy policeman. It captures a criminal maybe once every few hours.
So what does heparin do?
Heparin binds to antithrombin and changes its shape. It causes a conformational change. It acts as a catalyst. It cranks antithrombin into overdrive. It makes antithrombin 1,000 times more effective at catching thrombin.
So heparin is the coffee and donuts that wake up the cop.
Or maybe molecular handcuffs. Let's look at the unfractionated heparin, or UFH. This is the old school stuff. It's a long, long chain of sulfated sugars, very negatively charged. To inhibit thrombin, the heparin chain has to be long enough to wrap around both the antithrombin and the thrombin. It bridges them together.
Like a big bear hug involving 3 people. Heparin is hugging both the cop and the criminal.
Exactly. The Goodman and Gilman text specifies it needs to be at least 18 saccharide units long to do this. But, and this is key to inhibit factor Zea, the chain doesn't need to be that long. It just needs to hold onto antithrombin. The conformational change alone is enough to let antithrombin catch factor Zea.
This brings us to the low molecular weight heparins, like enoxaparin, which most people know as Lovenox. The name says it all. They're just smaller pieces of the chain.
Right. Scientists realized that the long chains of unfractionated heparin caused problems, so they chemically or enzymatically chop the long heparin chains into smaller bits. Because the chains are shorter, very few of them are long enough to form that bear hug bridge between antithrombin and thrombin. So, LMWH is really bad at inhibiting thrombin directly.
But it's still an anticoagulant.
Oh yeah, because it is excellent at inhibiting factor ZAG. And remember, ZAG is upstream. If you stop ZAG, you stop the generation of thrombin. The ratio of inhibition just shifts. Unfractionated heparin inhibits thrombin and ZAG pretty much equally, a 1-to-1 ratio. LMWH inhibits ZAGs about 3 times more than it inhibits thrombin.
Why does this matter clinically? Why do we use LMWH so much more now?
Predictability. Unfractionated heparin is. It's a sticky drug. It's a dirty drug. It sticks to plasma proteins, macrophages, endothelial cells. Its bioavailability is all over the place. You give a dose, and you don't know exactly how much is working.
So you have to monitor it.
Constantly. With a test called the APTT, the activated partial thromboplastin time, you're constantly adjusting the drip rate.
Which is a huge pain for the nurse and the patient.
Yeah.
Nobody wants a blood draw every 4 hours.
A huge pain. LMWH doesn't have that baggage. It doesn't stick to everything. You give a shot under the skin subcutaneously, and you know almost exactly how much is working. You don't need to monitor the APTT. It's weight-based dosing. For our patient with the PE, this is likely what she gets first. A shot of enoxaparin.
There was an even smaller version, though, right? Fondaparinux.
The synthetic sniper. Scientists analyzed the heparin chain and found the absolute minimum sequence needed to activate antithrombin. It is just 5 sugars long, a pentasaccharide, and they just synthesized it in the lab.
And since it's so short,
It has zero thrombin inhibition. It cannot bridge. It is a pure factor ZA inhibitor. It's extremely precise.
so we have the heparin family.
Yeah.
But we have to talk about the universal risk of all these drugs: bleeding.
Every single anticoagulant increases bleeding risk. It's the trade-off. We are inhibiting the body's ability to seal leaks. If you give too much heparin, the patient might bleed into their brain or their gut. We need an antidote.
Protamine sulfate.
Yes. Protamine is a highly positively charged protein derived from salmon sperm, actually.
Really?
Yeah. And heparin is highly negative. They stick together like magnets, neutralizing the heparin. But here's a nuance from the source text that can save a life. Protamine works perfectly on unfractionated heparin. It only partially reverses LMWH, maybe about 60%. And it does not work at all on fondaparinux.
That is a scary thought. If you overdose fondaparinux, you just have to wait it out.
Yeah. Essentially, yes. Or you give clotting factors to try and overwhelm it. But you can't just turn it off with a switch. This is a classic example of the trade-off. Fondaparinux is easier to use, but much harder to reverse.
Before we move off parenteral, the injectable drugs, you have to mention the alternative. What if the patient is allergic to heparin? I've heard of HIT heparin-induced thrombocytopenia.
HIT is a fascinating and really dangerous paradox. It's an immune reaction. Sometimes the body forms antibodies against the complex of heparin and a protein called platelet factor 4.
Yeah.
And these antibodies actually activate platelets. So you give a blood thinner, but it causes massive clotting.
That is wildly counterintuitive, an anticoagulant causing clots.
And because the platelets are being used up in these clots, the platelet count drops, which is the thrombocytopenia part. If a patient has this, you cannot give them any form of heparin. You have to switch to a direct thrombin inhibitor.
Like bivalirudin or argatrobin?
Exactly. Bivalirudin comes from leeches. Originally, yes. Hirudin is the anticoagulant in leech saliva. It's how leeches feed without the blood clotting up on them. Bivalirudin is a synthetic version, and unlike heparin, it doesn't need antithrombin. It binds directly to thrombin, no policeman needed. It grabs the CEO and gags him directly. It binds to both the active site and the substrate recognition site.
Nature really has thought of everything. Okay, so our patient is stabilized in the ER with heparin or LMWH, but she can't go home on daily injections. Well, she could, but nobody wants to. We need a pill.
Enter the oral anticoagulants. For decades, we only had one real option: warfarin.
The rat poison.
It was used as rat poison, yes. It makes rats bleed to death internally.
Right.
But it's been the gold standard for humans for 60 years. And warfarin works completely differently than heparin. Heparin works in the blood. Warfarin works in the liver.
It's a supply line attack.
Precisely. Remember those GLA residues we talked about, the calcium anchors? The liver needs vitamin K to make those anchors. But here's the trick. When the liver uses vitamin K, it oxidizes it. It turns it into vitamin K epoxide. To use it again, the liver has to recycle it back to the active form.
Recycling is key.
And it uses an enzyme called VKORC1, vitamin K epoxide reductase. Warfarin blocks that enzyme. It stops the recycling plant.
So the liver runs out of usable vitamin K.
And it starts pumping out dud clotting factors. Factors 2, CX, and X are released into the blood, but they are defective. They can't stick to platelets. They can't clot.
But here's the catch, and this is the concept that trips up so many students. You take a warfarin pill right now, and basically nothing happens for days. Why?
Because warfarin does nothing to the factors that are already in your blood. Those factors were made yesterday. They have their GLA residues. They are fully armed and operational. You have to wait for them to die of old age.
And they all have different lifespans.
Right. Factor 7 has the shortest half-life, only about 6 hours. So factor 7 levels drop first. But prothrombin, factor 2, has a half-life of 50 hours. That's over 2 days. So you don't get full anticoagulation for 4 to 5 days.
This is why we have to bridge. You can't just give our PE patient a warfarin pill and send her home. She'd have no protection for 5 days.
Exactly. You keep her on the heparin, the bridge, while you start the warfarin. You wait until the warfarin effect kicks in, which we measure with the INR test, before you stop the heparin.
Now, here is where it gets really, really interesting. The protein C paradox. This blew my mind when I first read it in Goodman and Gilman. Warfarin can actually cause clots in the first few days.
It's a cruel irony of biochemistry. We mentioned protein C earlier. It's one of your body's natural anticoagulants. It puts the brakes on clotting.
Right.
But guess what? Protein C is also vitamin K dependent.
Oh no. So warfarin stops the production of protein C too.
Yes. And worse, protein C has a very short half-life, similar to factor 7. So when you start warfarin, protein C levels crash first. But the procoagulant factors, like factor 2 and X, are still high, so you lose the brakes, protein C, while the engine, thrombin generation, is still running.
So you are temporarily in a hypercoagulable state.
Yes. This can lead to a rare but horrific side effect called warfarin skin necrosis, where microclots form in the skin vessels and the tissue dies, turning black. It usually happens in fatty tissues like the breast or abdomen.
And this is another reason why we must bridge with heparin.
Absolutely. The heparin covers you during that dangerous transition period until the factor 2 levels finally drop.
Warfarin sounds like it's high maintenance.
It is the ultimate high-maintenance drug. It has a narrow therapeutic window. Too little, you clot. Too much, you bleed. And everything interacts with it.
Like salad.
Yeah, leafy greens are full of vitamin K. If you eat a giant kale salad, you are essentially giving yourself the antidote to warfarin. Your INR drops and you are at risk of clotting. You have to keep your diet really consistent.
And other drugs.
The list is endless. Drugs that induce CYP enzymes like barbiturates or rifampin make the liver chew up the warfarin faster, making it ineffective. Drugs that inhibit CYP enzymes like amiodarone or certain antifungals stop warfarin metabolism, causing levels to skyrocket and leading to bleeding. CatSwing has a table of interactions that spans pages.
It requires a real lifestyle commitment. Regular blood tests, those INR checks, watching your diet, checking every single new medication.
Which is why the new drugs that DOACs have basically taken over, the direct oral anticoagulants.
The fire and forget drugs.
Essentially. We have the Zabin's rivaroxaban, also known as Xarelto, apixaban, or Eliquis, and adoxaban. As the name suggests, they inhibit Factors A directly. And then we have dabigatran, or Pradaxa, which is a direct thrombin inhibitor.
What's the advantage?
Convenience. It's fixed dosing. You take 1 pill a day or twice a day, no INR monitoring, no dietary restrictions. And clinically, they seem to have a lower risk of intracranial hemorrhage bleeding in the brain compared to warfarin.
That sounds perfect. Why does anyone still use warfarin?
Well, cost is one. DOACs are expensive. But also, renal function. DOACs are cleared by the kidneys. If the patient has kidney failure, you can't use them, or you have to be very, very careful. Warfarin is cleared by the liver, so it's safe for kidney patients.
And mechanical heart valves. I remember that being a big one.
A crucial point. If a patient has a mechanical metal heart valve, DOACs do not work. We learned that the hard way in the Reline trial. Patients with mechanical valves on dabigatran had more strokes and heart attacks than those on warfarin. Warfarin is still the absolute king for mechanical valves.
Okay, so for our 25-year-old patient, she has normal kidneys, no mechanical valve.
She is a prime candidate for a DOAC. She could start on rivaroxaban or Epigat immediately. Some of these protocols don't even require the heparin bridge anymore. You just start with a higher loading dose of the oral drug to get levels up fast.
That is a game changer for keeping people out of the hospital. It transforms a 5-day admission into an overnight stay or even an outpatient visit.
Absolutely, a massive change in practice.
So that covers anticoagulants. These are the drugs that inhibit the cement, the fibrin. But what about the bricks, the platelets? We take aspirin for heart attacks, but warfarin for DVTs. Why do we treat arteries and veins so differently?
It comes down to flow. It's a physics problem, really. Arteries have high pressure and high flow. The blood is rushing by. In that environment, the main driver of a clot is the platelet. The sheer force itself activates them. We call these white thrombi because they're mostly just platelet clumps.
So for an artery problem like a heart attack or a stroke,
Yeah.
you need an antiplatelet.
Correct. Veins, on the other hand, are low pressure. The blood is sluggish. Stasis. In that stagnant pool, the coagulation cascade has all the time in the world to activate and build a massive fibrin net that traps red blood cells. We call these red thrombi.
So for a vein problem like a DVT or a PE, you need an anticoagulant.
Exactly. You match the drug to the plumbing. Giving aspirin for a DVT is like, I don't know, bringing a knife to a gunfight. It's just not the right tool for the job.
Let's talk about the big daddy of antiplatelets, aspirin.
Aspirin is incredible. It works by inhibiting the enzyme cyclooxygenase 1, or COX1, inside the platelet. This completely stops the production of thromboxane A2. Remember, thromboxane is one of those recruiters that calls in other platelets.
And aspirin is irreversible, right? That's the key.
That is the key feature. It creates a permanent bond. It acetylates the enzyme's active site. And here is the kicker. Platelets have no nucleus. They have no DNA. They cannot make new enzymes.
So once a platelet's enzyme is broken,
it is broken for life. Once a platelet is aspirinized, it is disabled for its entire 7 to 10 day lifespan.
which means even if you start taking aspirin today, your bleeding risk lingers for a week until your body makes all new platelets.
Right. Surgeons hate this. They have to wait a week before operating if they want to minimize bleeding.
Then we have the superaspirins, the ADP blockers, Plavix or clopidogrel.
These target the P2Y12 receptor, which is the receptor for ADP. If aspirin blocks one ear of the platelet, the thromboxane ear, clopidogrel blocks the other ear, the ADP ear. We often use them together. Dual antiplatelet therapy, or DAPT, to make sure the platelet really can't hear the signal to clot. This is standard after placing a coronary stent.
But clopidogrel has a genetic quirk, doesn't it?
It's a prodrug. It's inactive when you swallow it. Your liver, specifically the CYP2C19 enzyme, has to metabolize it into the active form.
And some people.
Some people are poor metabolizers. About 15% of Caucasians and up to 30% of Asians have a genetic variant where their CYP2C19 is lazy. They take clopidogrel, but it never gets activated properly. They get no protection.
That is terrifying. You think you're protected, but you're still...
Well, that's why we have newer agents like ticagrelor and prasugrel, which don't rely on that specific activation pathway as much. They are more potent, but again, the trade-off, they carry a higher bleeding risk.
Yeah. There's one more class of antiplatelets, the real heavy artillery, the GPIIBA inhibitors, abcicimab.
This blocks the final common step. Remember the handcuffs, the receptor that grabs fibrinogen. These drugs jam that receptor. It doesn't matter what pathway stimulated the platelet ADP, thromboxane, thrombin. If it can't grab fibrinogen, it can't aggregate.
It cuts the hands off.
Effectively. These are given IV in the cath lab for high-risk heart procedures. They basically shut down platelet function entirely for a short time.
Okay, so we've prevented the clot with anticoagulants. We stopped the platelets. But what if the clot is already there? What if our patient is unstable, dying right now from that PE? We need to blow it up.
Section 5. Fibrinolytics, the clot busters.
The nuclear option.
This system relies on a protein called plasmin. Plasmin is a molecular scissor that cuts fibrin. It circulates as an inactive precursor called plasminogen.
And to activate it, we use TPA, tissue plasminogen activator.
Your body makes TPA naturally. When you heal a cut, your endothelium releases tiny puffs of TPA to dissolve the scab over time. It's very localized. It binds to the fibrin and activates plasminogen right there on the clot.
But when we give it as a drug,
we give a massive dose, alteplase, retzelplase, tenecteplase. We flood the system. This completely overwhelms the natural inhibitors. It turns all the plasminogen in your entire bloodstream into plasmin.
So you have these molecular scissors running wild everywhere.
And they don't distinguish between the bad clot in your lung and the good clot that is keeping an old stomach ulcer from bleeding or sealing a tiny tear in a brain vessel.
That's the systemic lytic state.
It dissolves the PE, which can save your life. But it carries a very high risk of causing a catastrophic brain bleed, a hemorrhagic stroke. That's why we reserve these for life or death situations.
So for our patient,
if our 25-year-old patient had low blood pressure, if she's collapsing, we might risk it. But since she is stable, we stick to anticoagulants and let her body's natural TPA dissolve the clot slowly over weeks.
We have to mention the antidote to the clot busters too. If someone is bleeding because their fibrinolysis system is overactive like in trauma or hemophilia, we give aminocaproic acid or tranexamic acid, TXA.
These are very clever drugs. They are lysine analogs. Here is the mechanism. Plasmin binds to fibrin at specific spots called lysine residues. It docks there before it cuts. These drugs look just like lysine. They act as decoys.
So the plasmin binds to the drug instead of the clot.
Exactly. It fills up all the binding sites on the plasmin. It blocks the scissors from ever reaching the fibrin mesh.
It effectively puts a sheath over the scissor.
That's a perfect analogy.
Yeah.
TXA is becoming huge in trauma medicine. It stabilizes the clot and buys the surgeon time to fix the bleed.
So let's bring it all back home. Clinical integration, our 25-year-old woman.
She's in the ER. She's stable. So step 1, immediate anticoagulation. We start LMWH, enoxaparin shots, to halt the clotting process immediately. Or, if the hospital protocol allows, we start a direct loading dose of a DOAC like rivaroxaban.
Okay.
Step 2, decision on long-term. She doesn't have renal failure. She's young. She likely doesn't want regular blood tests. A DOAC is the likely choice for her.
Step 3.
Duration. This was a provoked clot. The oral contraceptives were the trigger. That's actually good news compared to an unprovoked clot. It means we know the cause. We treat for 3 to 6 months.
And step 4. Stock the oral contraceptives.
Absolutely. She can never take estrogen-containing birth control again. It's too risky. She will need to find an alternative method of contraception.
And what about atrial fibrillation? We mentioned it briefly.
AFib is the other massive bucket of patients. The top chambers of the heart, the atria, just quiver. They fibrillate, so blood pools there, you get stasis. And stasis leads to clots. Those clots can then travel to the brain, causing strokes.
And because it's stasis, a venous-type flow problem.
We treat with anticoagulants, warfarin or Oasis, not antiplatelets. This is a common mistake. Aspirin does not prevent strokes in AFib effectively. You need the heavy-duty stuff.
So summing up this entire deep dive into Pharma 32. 1. Hemostasis is a balance. Too much flow equals a bleed. Too much solid equals a clot.
2. Platelets are the bricks for the arterial side. Fibrin is the cement for the venous side.
3. Heparin bridges, antithrombin. Warfarin cuts the supply of vitamin K factors. DOACs are snipers hitting AXA or thrombin directly.
And 4. Fibrinolytics are the nuclear option to dissolve what's already there, but with a huge risk.
And the final takeaway. These drugs are not blood thinners. Right. My grandma calls them blood thinners.
Everyone does. But they don't change the viscosity of the blood. It's not like watering down paint. They change the probability of clotting. They retune the sensitivity of a system that evolved to save us from, saber-toothed tigers, adapting it for a modern world of sedentary lifestyles, surgeries, and long-haul flights.
We are literally hacking the code of our own survival mechanism.
We are walking the tightrope.
I love it. If you want to see the diagrams, and trust me, the cascade makes way more sense when you see the pictures. Check out Chapter 32 in Goodman and Gilman and Chapter 34 in Ketzon.
The molecular diagrams of the heparin antithrombin bridge in G&G are particularly enlightening. They really make it click.
Nerd.
Proudly.
That's all for this deep dive. Stay fluid, everyone.
Not too fluid.
Keep the balance. We'll see you next time.